So, citizens' voices can be quite loud. So, welcome very much to the first ever NHS Citizen Assembly meeting. This is... I am as excited, if not more than that, because this is the culmination of a lot of work of a lot of people. So, just quickly, I'm assuming all of you know what NHS Citizen is because you're here, but NHS Citizen is a whole system attempt to hold the board of NHS England to account. It's got a number of different layers, and I'm only going to talk to you about two of them right now. Yesterday, we had our first test of what we call the gather layer. And the gather layer is the place where people who think there is an issue for the board to listen to plant a flag, have a conversation about it, and then a decision is made as to whether it's an important enough issue to come to the board, to come to the assembly meeting. So we were expecting about 20 ideas, and we got 56 ideas. And the system didn't work perfectly. We've got lots of things to get right about gather, but one idea stood out of a number of ideas, and the idea that we want to discuss today within the assembly meeting is the following. And it's just behind me, but I'm standing in front of it. And the idea, what we want to know is, how can we really make NHS England information accessible and understandable to patients, carers and citizens? So, what we're not here to do is to reach a decision and get the board to commit to spending lots of money. What we're here to do is to hear... we haven't got any, says Victor. What we're here to do is to hear lots of different perspectives about this issue, to deepen the understanding of the board about this issue, to deepen the understanding of the people here about this issue, and then to reach the point where we think we understand the issue better, and the board goes away saying, this is how we're going to carry this on to get to the point where we can reach action. We're not going to get to action today, but we're hoping to hear a strong commitment from the board about this is where it's going to go next, and this is how we think we're going to get to a point where change will happen. So, we're hoping to deepen understanding, broaden debate. Many of these issues raise all sorts of huge passions. So we need to be listening to each other and respecting each other's views, because there are multiple views on these sorts of issues, because we're trying to hear the multiplicity, all of the different views, rather than just one or two of them. So I know what I'm going to do, and I'm pretty clear about how this is going to work, but I've also got plans B, C, D and Z, because there's multiple things that could happen when we start inviting lots and lots of people to question those who've got the most power in an organisation. So without further ado, I'm going to hand over to my colleague Camilla Child, who's going to introduce the issue to us and bring lots of different voices in. Camilla.
Thank you. Hello, everybody. Simon said, the issue of the day, and I'm just going to repeat it because it's impossible not to stand in front of it. How can we make NHS information accessible and understandable to all patients, carers and citizens? And through our process yesterday, in the gather process, and in talking to lots and lots of people, as we have done over the last couple of days, we've found some really interesting people who are able to speak from their own perspective to this issue. And we are delighted to be able to welcome Joanne, who's going to talk first, and then John afterwards. Sean, my hearing. After that. So first of all, and you're from Change Organisation, do you want to come here and talk? And you're going to tell us about that issue from your perspective. Okay. And you have to hold it quite close.
I've got a learning disability, so I'll tell you my story about when I went to the doctors. Okay, first time I was living with my sister, so I went to register at the GP, and the form was not made accessible for a person with a learning disability. So I tried reading hard, so I can't read any of the words, and the small printed. So I said to the reception, can you help me? I have a learning disability. She said, no, I am not trained to work with people with learning disabilities. And I felt that little. I felt like I was very embarrassed by going to that doctor's surgery. So I think this area...
That's fantastic. Thank you very much, Joanne. And I'm going to pass it to Sean.
My name is Sean Webster. I've got a learning disability too. The information is not good enough. Letters how people talk, it is jargon. When people have apartments, how can I read the letter? Is it letter in double Dutch, in jargon? How doctors talk to people with learning disability is not long enough. It's 15 minutes. It's a joke. And when doctors talk to them, the patients can't understand what they're talking about. If people with learning disability take the medication, that I wish to take overdose because they don't understand what is happening. Because you can't read how you're going to take your medication right. Everything's got to be jargon-free, plain English, and accessible.
Thank you, Sean. Okay, what we wanted to do was to introduce as many different perspectives on one issue, sort of a broader accessibility issue, as we could. And I think, Dawn, if it's all right, are you expecting this? Sorry, I was told Dawn. 2 names wrong. That's terrible. Would you mind saying a few words?
Okay. I'm coming from quite a wide perspective on this of communication, and I think what is actually functionally important as regards what people can access as information needs to be looked at first of all. I'm a member of a patient participation group for a GP practice, and one of the first suggestions that we had from patients was that when flu jabs were around and available, it would be really good to have it up on a website, that the practice website, so that people could actually know where and when to go and get their flu jabs. But also within that PPG, we've tried to contact people who are housebound, and we've sent out we would like to send out suggestion slips via the district nurses. We're not quite there yet because the doctors aren't sure that that's what they want to happen. But again, it's ways of just being able to interact with people who don't get out of the house at all, and the district nurses are really their main communication. So the other thing that happens is quite often there are areas of the NHS who don't actually know what is going on elsewhere, so they can't signpost. So it may be that something is happening very locally, but staff members don't know, so there's no way that they can pass that information on. That is quite general with a lot of organisations, though. And it's quite useful for local media. I realise from having builders in my house for ages that people listen to the radio kind of sometimes all day, every day, particularly older people and young people in the home. Let's just get some of these messages out via local radio. There are big messages that the Inland Revenue now put out, newspaper advertisements, etc. The NHS can do that as well. So a bit more general from my point of view, but I think we need to look at communication, not about comms teams who really do come out with a fair bit of jargon, but actually people that are connecting on a daily basis with the public to actually have that information and make it easily available. Just think, in Hull we have 20% illiteracy, so we have to think about different ways of getting that information out.
Thank you very much, and sorry again about your name. Charlotte, I know her name is Charlotte because I checked it with her. She came and spoke to us very passionately yesterday about several issues at the Gather Space, so we specifically also asked her to come and talk about them again today, so I'll hand the mic to you.
I'm following a lady who was lucky enough to be able to join her patient participation group. My GP surgery won't allow me to. They say, unfortunately, it's been running for quite a long time. I think the unfortunate word is very interesting, but they still won't let me join. So I leapt over their heads and went to work with the CCG instead. I I have a bugbear in respect of health issues, of which dementia is a health issue. It's only described by a consultant as a rule in the NHS. This makes it a health issue. It is not a social care issue. It's not a question of doing the washing up for somebody. It's a question of ensuring that their welfare remains good. Dementia is not in isolation. If there is another problem going on, it's put down to dementia. I nearly lost my husband over Christmas because of that. We have to start considering the person as a whole being. In his case, they were considering him as an esophagus. It's not much of a life, an esophagus. So, as the other problem that we have is that I'm a family carer as well. I am told constantly from all directions that the problem is that with family carers their health can break down, and for their health they must take respite. They must keep up with their social life as well. Not sure how, and in any case, when you go to ask for health respite so you can carry on caring for somebody, keeping them off the community's books for care, you're not allowed it. You have to go to social care. The whole idea of this is to toss you about like a ping pong ball until there's nothing left of you. You're too exhausted to fight back. I know we're not supposed to be too difficult, but on the other hand, the reason I was asked here was to have my say. What we need in the community to make us communities again is something which I am aware happens in some communities, and that is a centrally funded and centrally placed community centre. Not a social care centre, not a health centre. A place where we would all like to go. The place where we would all feel welcome. Where we could do all the volunteering that people are doing in droves across this country already, but it would be a central focus for collecting volunteering jobs that we could then go out and do. A place where we could learn from, say, U3A, which, if you're older, which is a lot cheaper than adult education as a rule, and you often get professors in that who have retired but not quite. And we could do things like helping in the library, which would be in the same building, because everybody is asking for volunteers for library work at the moment because nobody's prepared to pay librarians. What we need is a social centre that we can actually get to. In country areas, there isn't the public transport to be able to get out and about. There is school transport. Why can't that be extended out of the joint social care and health funding so that we can actually get to places? And having got there, we can keep our friends. Having got there, we can make new friends. Having got there, we can be so damn busy that we won't have time to be ill unless it really strikes us hard. But if we are ill, we will then be able to get to the GP surgery, which will be close by. We'll be able to get to the optician, to the dentist, to the local hospital. If the place is central, we will be able to get to places where a lot of people currently can't get. And we will also have the public transport in place, and we will be supporting it by using it well, so that we can all get about and we aren't left to be terminally lonely. We need a different way of thinking. We also need for the current health and social care professionals to be retrained so that they look at our needs first, because we are the point of their existence, and this is time now to change it.
Wonderful. Thank you. Thank you so much. I think you've probably covered every angle between all of you that there could be. And I was... Pardon? I would like just to invite our board members now just to give us their first reactions to and what their perspectives are on what they've heard. Can you just sort of play back what you've heard to us? I think... Have you got the...
So I think there are kind of I think this is an incredibly important question. Not just in the context of the, the care.data leaflet, which I guess probably prompted it, but on a much, much bigger basis. And actually, personally, I've spent the whole of my career looking at how we make information in one way or another more useful to people. And actually, it is, for me, the key to a modern health service. But I think there are 4 things that we need to do. And I'm not sure I have all the answers. So I think that's something that I'd be really interested in hearing from people here as to what some of those answers could start to look like. But the first one is that just simply the information that is provided just needs to be hugely more accessible. I actually set up, and I do regard this as a privilege, NHS Choices, which is the NHS's online information service back in 2007. And I think actually we can be pretty good at being imaginative and creative about ways of making sure information is really relevant to the person who wants it in all sorts of different ways across different kinds of media and so on. But I think there's an awful lot of work that we haven't done. And I can't really explain why, because there's been so much, collaborative work with voluntary organisations, with patients and others to try and raise the bar of patient information, and yet it still hasn't really raised, in my view. So I think there's a whole bunch of stuff there that we need to do. The second thing is I became really conscious over the last few years, and I'm feeling like I'm whispering because it's so loud, but that's probably just because I'm in front of the speaker, that there are a huge number of people, a minority but still a very large number of people, who for all sorts of reasons just are not able to engage, have not been able to engage with the sort of digital opportunity, the online opportunity for accessing information in a fantastically interactive way. So we want information to be useful to people. The digital technology offers us huge opportunities to do, not for everyone, but for a very large number of people. And health literacy, and particularly digital health literacy, has got to be a major priority for NHS England. I don't know if people know this, but we've launched a programme with what was UK Online and is now the Tinder Foundation to fund 100,000 of the most disadvantaged people in our communities who wanted to learn how to use digital technology better. And that programme is ongoing at the moment. And I think already more than 70,000 people have now been helped, supported to understand how they can use the internet to achieve kind of answers to some basic health questions. But this is just a beginning. But I think health literacy is a really important theme. Third thing is the lady here was absolutely right to talk about this being something that relates to staff, and indeed some of the speakers here, as well as patients. We've got a lot of work to do with our own staff, our own colleagues in the NHS, who are all there because they want to make a real difference to patients, but who in some cases just don't know quite how to deal with this information revolution that's taking place. So we want to do a lot more work with them. And then finally, for me at the end of this, and it's not quite the question, but in a way, if the NHS can't be good at information, and in the sense of not just helping people with information, but also listening to them when they have information to give it. So, for example, helping people who are often in hospital not have to repeat over and over and over again who they are, what their condition is, with great risk actually to themselves. In other words, an organisation that can remember who its patients are, that can work with information about them as well as provide them with information to help themselves, is a modern health service. And just saying that feels to me like we're quite a long way from where we need to get to. So I would really appreciate thoughts about what we can be doing, but it is fundamental to the success of NHS England, I think.
Would you mind? I think it would be very nice if because I saw hands going up. No, Tim, that's absolutely fine. Hands going up, people wanting to say something. What we're going to do now, we're going to come back to you, go back out, come back to Victor. Yep.
Good. Who do you want to hear from first, Camilla?
Hang on, there was a lady who wanted to... No. We didn't introduce...
That was a big fail, very sorry. Yeah. Just quickly, who are you?
My name is Victor Adibawali and I'm on the board of NHS England and the Chief Exec of Turning Point.
And I'm Kieran Devan, I'm also a non-exec on the board of NHS England. My day job is Chief Exec of Macmillan Cancer Support.
And my name...
Yeah, you are loudest.
My name is Tim Kelsey. I'm the National Director at NHS England for Patients and Information.
Okay, there was a gentleman here.
Excuse me, sorry.
It's like being a pop star.
Thank you. Okay, my name is John Taylor. I do quite a lot of things. I'm very much involved in digital. In fact, so much involved with digital stuff that I'm actually not here. I'm actually a hologram. And I believe I'm in the second world. However, Denise brought up a lot of points about communication, and Tim has as well. There is one line of communication which I believe will be very fruitful, particularly with our colleagues, patients, family who are not digitally inclined, like my wife. And that is, why do we never, like when we have a disaster thing on a soap, why don't we ever have references to these services that we have? Why do we never have summary care records mentioned? Why do we not have prescriptions and whatever? Why do we not have, after the event, say someone on Emmerdale has a heart attack, we don't get mentions of cardiac support groups? That's dear to my heart, which is a pun, I know, but I actually am the only living founder-patient member of the Bolton Cardiac Support Group, which we founded in 1990, and I chaired it for the first 10 years of his life. But we don't get these things on. If it was a commercial organisation, they would be fighting tooth and nail to get sacks of salt or Kellogg's cornflakes on the table. Why can't we do it? The BBC is a publicly funded organisation. Surely we have some influence. Sorry, that's my rant over.
Thank you very much. I'm going to take you, catching my eye like mad.
So this lady here, Charlotte, when Charlotte was saying about having a place to go, sort of to learn, one thing that was striking with me was reminding me of the recovery colleges. I don't know whether everyone's familiar with recovery colleges. I'm from a mental health background, I'm speaking at the moment. Got other backgrounds too, but mental health for this point. We have recovery colleges, and they're great places to go. You're a student, a bit like the pop-up university, very similar to pop-up university. You take on courses, not therapy. Now, these are a great idea, and I really encourage everyone to look these up. But we need to make sure they belong to the community, and they're not owned by the trust. It becomes a trust thing to show we're doing recovery. And the thing is, we had equal partners with our recovery college, but the thing is, they didn't have an equal stake in the pot. So I kind of feel we need a social enterprise that's going to run these recovery colleges, get a building, the community owns it, it's all equal stakes, and then we can have the courses, we can have everything that Charlotte's saying, and it just makes sense. That's it, really.
I think, sure. Okay.
On behalf of Change in Leeds, my name's Bally. I asked this lady here about going to libraries. I'll tell you a story about libraries. Going to libraries these days, we'll find out information about how to use computers, how to speak to librarians, and how to get information about different kinds of books you want to read. If you can't read, they will help you to read the books that you want to choose. That's all I'm going to say.
Okay. One more. If Sean can come back because he's had his go, and then I think we'll move to Kieran. That's right.
Okay.
Oh, sorry. Oh, sorry. Do you know, if you could hold your question, what we're going to do is we're going to hear from Kieran afterwards, and then we'll come back to you after that, if that's all right.
I've never heard of NHS Trust. I've never heard of it before. And either read NS.
Christ, let's get this through. Yeah. So the answer is it is easy read, and it's available as a digital tool, accessibly to all sorts of users. So, and in fact, they're here today. I'm not quite sure where the stand is, but anyway, NHS Choices is in this room, and they'll help you get access to the service.
Choice. I never heard it before. Nobody told me about it. Why it's not my friend heard of it.
Put the microphone to the mouth.
No, my friends heard it. And why is that?
Yeah, well, that's a really good challenge. Actually, it's pretty popular. There are now about 20 million people who use it every day, different people, but every month. Sorry, but that's a really good challenge.
Thank you.
Okay, I'm going to pass the mic to Kieran. This one, thank you very much.
Thank you. I think I've heard a few things, and a little bit of background. In Macmillan, one of the things that we are conscious of is what Sean actually was mentioning about jargon. And, no matter who you are, there's a temptation to try and throw out the information that you think somebody should hear rather than the information that's helpful to them. And there's also a temptation to throw the information out in the way that's comfortable for you rather than the way that's comfortable for them. So I think we need to start thinking about how we do information in very plain, straightforward language, sometimes written, but what about language information which doesn't have to be written? What about audio tapes for the 20% of people in Hull for whom something written, no matter how well written or simply written, doesn't work? And then maybe back to Joanne's point at the very beginning, around supported information. It's not just the information that matters, because even for people who've been to university or whatever, their decisions are different, not when they get the information, but when somebody talks them through. So we need to see information as part of something bigger. It's about knowledge and how that information turns into something which is really helpful that matters. And the last bit for me, and maybe it's a question, if one thing is let's provide information in different ways, that opens up the question of different languages. It opens up the question of digital but non-digital. It opens up the question of using community spaces so that it's people talking to each other that matters. And I completely take the point of if only the NHS knew what the NHS knows, it might be a step forward as well. So there's something for me, maybe, I think I'm hearing, so tell me if I'm wrong, around it. It's not seeing information as one product produced in one way, it's printed, and that's the end of the story. It's actually, we need to consciously say that almost by default there'll be a whole range of ways of presenting information, and then see if that works. But happy to be challenged on that too.
Kieran, thank you very much indeed. So I'm going to come to questions. I've got you, and I'm looking around now for others. I've got another one over there. And another one there. I'm going to take those three, and then I'm going to do a little bit of reflection myself to try and untangle a few things, and then I'm going to come back again to you, and then go to Victor, and then we'll see how far we've got. So, yes.
Hello, I'm Zoe Matthews from Friends, Families and Travellers and a trustee of National Voices. I'm very concerned about groups of people who can't access information well. So obviously gypsies and travellers, there's a high levels of or rather low levels of literacy. I think what Kieran was saying about having supported information is really important, because at the moment what tends to be happening is that I'm, as a health policy manager, I am bombarded with people who want to make information accessible to gypsies and travellers, which is great, but there's only one of me. And I'm doing a lot of the national work. There are some other great national organisations, but there's not many of us. The videos are really good. I know from feedback from talking to Gypsy Traveller colleagues, I think the little video that the King's Fund made, which actually explained the NHS changes to me in a way that I could understand, is really good. So we would definitely want more of that. But significantly, it has to be supported information. It's no good. I can get leaflets made, easier to read, but when I present them to people, and unless I can go through it with them or signpost them, it means nothing. It's not going to go anywhere.
Thank you. Thank you very much indeed. That's connecting up to the kind of lack of connection in the NHS as well, and kind of the challenge it places on those people who are making connections, which raises significant questions for me, I think, for the board. Yes.
Hi there, my name's Sarah Roberts. I work for the Information Standard, and as a lot of you are probably aware, we have a lot of support from third sector organisations who produce some fantastic patient information. But part of what we do is certify those organisations for producing clear, up-to-date, evidence-based quality information, and part of that is ensuring that they user test their information and they regularly review it. Macmillan, of course, are a member. But what we do see is that there are very few trusts and NHS organisations and also local authorities who are prepared to do the same. So that would be my challenge back to you, is that third sector, great, NHS organisations, less great.
Just wait a sec, Victor.
I just want to ask whether, is NHS England a member?
Not per se. NHS choices are.
Fiona.
Hello, hi. Hello, my name is Fiona Carey. I'm a patient rep. And given that we're talking about accessibility as the main issue, I'd just like to pick up on a couple of things, particularly to ask Tim, because I think Sean's point about NHS choices is really key. Sean hadn't heard of NHS choices, so there's clearly a way still to go in terms of communicating this kind of information resource. Also, I'm not entirely sure that it's very accessible. And although there may be people on an NHS choices stand here who are willing to talk Sean through that, they're not available to most people most of the time in most places. So we need to be thinking harder about getting information out generally, and in particular about serving this population who are already, a bit marginalised in the NHS and who we need to bring into the fold quite a lot. Because this is about information as well, I suppose this also brings the question about care data and why we're not getting that right in terms of communicating that and ensuring the safety of this information. I don't think anybody here needs persuading about the value of big data and the health benefits for the whole population of being able to manipulate and research through that data. But we do have to be very, very, very careful about how we look after it, because once that trust is gone, it's really gone, and it's going to take a lot of building up. So a bit of a way to go there as well, I think.
Yeah. Fiona, thank you very much. I'm just going to disentangle some issues. I'm certainly going to come back to as many people as I can. There have been issues, I think, that are within the gift of NHS England that are around things like how you present materials in terms of the abilities of different people to understand different types of materials. There are things that are about connecting up the NHS better. Then there are things that are less to do directly with NHS England, but are clearly part of the role of NHS England. And some of these are about the connection of services, community centres and so on that you can't solve yourselves. And so one of the questions that I have is who else needs to be in this conversation to make some of these things connected up so that everything is accessible more? Because we have to accept that these guys can't change the world, but they can change quite a lot. So who else has to be in the room to make these things possible? There's sets of issues around different roles that people play inside the system. And then we've got a whole set of other issues being opened up by Fiona there around making information accessible to the system as well as to individuals. So I am going to make sure that you three have at least one more go at the bite at the cherry. There's lots of other people here as well. What I'm going to do next, I'm going to ask Victor to give a very brief... Okay, he'd rather hear from Tim. That's fine.
Tim had a specific... Is this on? Tim had a specific question. Do you want to ask it? It was very brief, and he's going to keep it brief.
Yeah, sorry, I wasn't going to say... yeah. Hello? Yeah. Yep. The question was just on that point of NHS choices. How many... Show of hands, please. How many people have heard of NHS choices? Okay, I just wondered because... and actually, those who haven't heard of it, if they did have time, it'd be really helpful if they could visit the stand, not to learn for themselves, but to explain how they think we should be doing better on making people aware of it.
Victor, I'd be interested just to hear a brief reflection from you, from your perspective as one of the non-exec directors, about what you've heard, the issues that you're beginning to distill in your mind, and things that it raises in your head about other things you'd like to hear from the people here.
Okay, well, the first thing I'd like to say is I think we ought to have more of this, because I actually think it's really useful, because it's grounding in a really sensible way. So, I sit on a board, we get papers, we talk about stuff, but really what I'm interested in is what the impact is, really. So that's my first thought. We need to do more of this in a way. But my second thought is, I've been thinking about this for a long time, right? And I just want to try this out on you, see what you think. It's going to come off as totally impractical. But I wonder, if we had have designed NHS Choices, or indeed NHS England for that matter, but started with the idea of communicating with people with learning disabilities first, not last. No, just as a, I'm not saying this for the class. It's just I'm genuinely interested in whether this would work. And we started with, we want to communicate with people, the Gypsy and Traveller community, or people from other countries or other communities. I wonder whether the rest of us would get a really fantastic job. Do you understand what I'm saying? So, for instance, if you look at the London Tube map, you know, if it was designed for the people who are most likely to be challenged by it, the rest of us would really be able to. So that's what I'm thinking. I'm thinking that, and I'm thinking that there's a real difference between information and communication. So there's lots of information out there. There's loads of data. There's less information, but there's lots of it. But there isn't much communication, and that's what I'm hearing. I'm hearing that actually we're not very good at communicating. We do a lot of transmit. We don't do a lot of receive, and we don't do a lot of co-creation. But I just wonder if we started with people literally designing the methodology, what it is that we're communicating and how we communicate, and we start with those people who are least likely to get it, I think the rest of us would get it. I want to know what you people think of that idea. The final thing is that fundamentally this is about culture. So we have a significant culture challenge in the NHS, and I'm sick of people slagging off the NHS. It is the jewel in the British crown, but we have a culture problem. And that culture problem is exemplified by the fact that, you know, when you go to your doctor, the doctor is taking risk, is thinking about risk from their perspective, not from yours. If you've got dementia, you're the one with all the risks, not the doctor. And that's the fun. So culture is the thing that I've gobbed on for too long, but that's the thing that gets me.
What I'm going to do, I'm going to ask you to reflect on Victor's question, and what he's done quite nicely is to start to begin to say, well, what if we did something different? What would that do to the NHS? So I want to give you just a few seconds to think about that. What if we did what Victor suggested, or what if we did something else different? What would that do to the system? And while you're thinking, Fiona said she wanted to just very quickly come back. So while you're thinking, you could ignore everything she's saying, so you can think about what you might say. Sorry, Fiona, that was a joke. And then I'm going to just there's time for 2 or 3 more people to give us that kind of what if, and then we're going to move into the next stage, which is kind of getting us slightly closer to action. Fiona.
Thank you for that vote of confidence, Simon. I just wanted to say really quickly that I think what Victor is suggesting is such a good idea. Because if you just look at something like architecture and accessibility, and the tube map is a great case in point really, you know, if you design a building that's accessible to the people who are most marginalised by access issues, you make it great for older people, you make it great for people with pushchairs, you make it great for people with big packages and shopping. You know, it makes life better for everybody. So I think if you start to address communication issues along the same lines, everybody wins, actually. I think that's a no-brainer. I think it's great.
Great. Thank you. Excellent, Fiona. Anybody else want to come back? I've got loads of people. Right. What am I going to do? I'm going to go to you. I'm going to privilege people who haven't spoken yet. I'm going to go kind of forward here and then to you. And then I'm going to see what time I've got. Yep.
Hi there. I'm Emily. I'm from the States, if you can't tell. And I'm tweeting at Wild and Crazy Pearl. So that's me. I'm with My Directives here. We're a U.S. company helping folks fill out advanced medical directives to share them online in the cloud, safe and free. And I was just wondering where that was in this conversation. What if we asked all UK residents to create a directive and store it online safely so that their medical medical wishes were honored?
Can I just jargon bust?
Sure.
3 words on what a directive is. I don't understand it.
Medical wishes in a moment of crisis or end-of-life situation.
Okay, come forward to here. I've got lots of people. I'm going to try and give as many people as possible a chance.
Hi, Hi, I'm Jackie Taylor. I'm CEO of Flying Binary. I'm one of the digital leaders for the World Economic Forum. And one of the things I'd say as a banking specialist is we've tackled the trust issue that's just happened with Care.Data, and we haven't tackled it from the centre. So every bank has owned the problem that it's created of trust in the industry. It's tackled it in a variety of ways. It's been profiled in a number of ways. But one of the things that we're working towards in the industry is giving our customers a permission-based data ecosystem that they choose to give to us on a policy level and withdraw when we negate the trust. And so I don't think that's a banking issue. I think that's something that could solve some of the problems in the NHS. So we can vote with our feet if the bank does what we don't like, and we can transfer allegiances. It can be permission for one transaction. It can be permission for a service. It can be permission for everything. So that's my ad.
What I'm hearing there is that's a different accessibility issue. It's about kind of creating ways that the system and individuals can have information, but ensuring that trust is built into it. So I think, was it you who had your hand up? I'm going to come here, and then I'm going to go there. Oh, I've got 3 more people. I know that you want to speak as well. Okay, go.
My name's Gopal Sandhu, and I'm from Bradford. And these are my colleagues who come to listen to your words of wisdom. And I think there's a lot of been issues which are kind of very personal to people. I think what we don't do enough of is celebrate the NHS, what it offers. And I think it's about time we celebrated our services and people who are dedicated and value those people in the front line. People who are receptionists, people who are carers, who provide the basics, even listening to people when they walk into a service. And I think we need to service and acknowledge their dedication and commitment. And it's not easy when somebody walks in with a symptom, something they're already frustrated. For a person to listen to a lot of patients during the day, it's not easy. It isn't easy. And I think you've just hit it, Victor. British service is jewel in the crown. I've travelled quite a lot, and I've seen healthcare, and nothing beats the British healthcare. And it's fantastic. I think we need to value that and celebrate that, and we can deal with the niggling things where there are issues. And I think in terms of communication, that's going to be a long-term issue because people have different needs, and we find different ways of reaching people. And I think if we present positive images and celebrate those through the media, through, like somebody said, the BBC are funded by the public, and through the programs that are on television, I think it's a fantastic way of promoting the NHS, and it's a learning tool for people. Those programs are learning tools.
What you're highlighting for me is the need to make the stories of where the NHS is succeeding as accessible as the stories where it isn't. I've got so many people that I'm not going to be able to give. You've got the microphone, so very quickly, and then I'm going to hand to you.
I'm Philippa Bragman. I'm the Director of Change. I think your idea, Victor, is a fantastic idea. I think the danger is that there's loads of new things happening and lots of changes happening, but at its core, we're still leaving out the people who are always left out. And I think the people who are always left out are the people who've got the most knowledge and expertise about inclusion and about communication and about information. And I think it would be brilliant in partnership with people with learning disabilities to address some of these issues.
Thank you very much. So come to you.
Hello, my name is Tamsin. I work with an organisation that does training and support for services and exiles. That's the name of it. So basically we work with migrants and refugees. My background is also working in adult literacy, and so starting from that point of looking at who's at the kind of like at the sharp end. I think if we can improve services for people with low literacy and also for people who don't have English as their first language, then we go a long way to improving services kind of more broadly. It's not just the actual words that we use in the communication itself. It's much broader than that. I've just done some research working with torture survivors about talking to them about their chronic pain. And the most important thing that came up from that was the context in which they experience that pain and the context that is there before they walk into the GP surgery. And if they're given a leaflet, what else is happening in their life as to whether they just ditch that or continue. So we really need to look at the context, and to do that we need to be able to do better outreach, have better contacts within the community. Yeah. Sorry, thank you very much.
So, is there a concentration of people who've survived torture in certain parts of the country? In other words, are there more people who've survived torture in London than in Leeds? Because that, for me, that says something about the nature of the service. So if you walk into a service in London, you would expect that service to be aware that you might be a torture sufferer, as opposed to, in the middle of, I don't know.
I'd say...
Just curious.
Yeah. I work with the organisation called Freedom from Torture, and they have a base in London, a base in the northwest here, and I think in Birmingham and in Leeds possibly also. The issue is one of invisibility, which goes back to what somebody mentioned earlier, that people don't self-identify kind of quickly. So essentially, if you have asylum seekers in your area, you will have victims of torture in your area.
So if we have areas like Newham, for instance, where there's a significant population, you would expect that to be, so therefore it would need to be part of the service configuration and therefore the communication. Okay, that's important.
Absolutely. Yeah.
So there's a kind of tailoring issue to different groups of people in different places who may be concentrated differently, which is quite a strategic issue. I'm going to hand over to you now. So can you hand it backwards?
On the behalf of people with disabilities, it would be good if we can work with you on those issues here today. We have some sayings, and now for over 21 years, we have been looking into a lot of issues, and we will continue to do so in the future. So it would be good to work alongside with you, friends, on these issues.
Fantastic, thank you. And what that's highlighting for me is that this isn't just about them doing stuff, but actually it's about us, because it is our NHS. I'm going to take the three people I've seen, so I'm going to take Ghazala, the lady next to you, and then you, and then I'm going to see what time we've got to and make a decision.
Yeah, hello, I'm Ghazala, and I'm just here as a person interested in making sure that people's voices are heard. I'm listening to Victor, and I do know if you've got people that have a lot of needs, you have a lot of things that you have to juggle and understand. And as when service designers, which should include the people that are using the services, they can help make sure that we look at each and every one of those obstacles that could possibly be in the way. And I think that's what Victor's saying, is that when you're looking at something, look at all the obstacles that could be in the way. I may not know all those obstacles, but there's somebody out there that does already know them. And therefore, once you've identified them, it's easy enough to say, well, what is the solution around them? So I think that approach is really, really good. And also it helps, it's a skill. Communication, you don't have it automatically. A trainee nurse, a trainee has to learn the skills within their profession of how to hear and listen to things. So going in with an assumption that you already know the answer isn't going to help. You've got to go in with an open mind. And that's what I'm hearing is, let's have more of an open mind that we don't know the answer, but there are people that have bits of the puzzle, and we need to get them all around and together and tell us their bits so that we can accommodate it.
Fantastic, thank you. Hand it just one. No, you're okay. Okay, we'll come here to you.
Sorry, ladies and gentlemen, it's going to sound a bit strange, but why don't the NHS idolize the Swedish model? You know what I mean? You don't. Sorry. You get the Swedes a bit more superior in quality. They've what I feel about that country, they've only got about 8.9 million people, and they have it in quality. I know it sounds strange, but...
I'm going to hand... it doesn't sound strange at all. I think there's lots we can learn from lots of places.
Yeah, and I think there's a lot that Sweden gets right. In my world, they are really, really good at two things in cancer. One is if something has to be specialised, they're completely relaxed about making sure it happens in a specialised centre, and lots of other centres don't think that they should kind of have a go. And the second one is at end of life, when people are dying, they are years ahead of practically every other country in helping people die at home. You can have a blood transfusion in your living room. If you want an intrathecal, a kind of an epidural kind of thing, you can have that in the community as well. So they're really creative. And I think we all have a lot to learn from each other, including here in England, where there's some really good stuff that happens here in Manchester, which isn't happening in Leeds, which isn't happening in Newcastle as well. So this thing about learning from each other, talking to each other, is critical, I think. So I don't think your question's strange at all. I think it's very profound.
Thanks, Kieran. Keep hold of that there for now. So we've only had an hour. We've got just a few minutes left, and we could do two things. We can either kind of keep opening the conversation and keep hearing more views, or we can kind of begin now to just push the board a little bit to say, how is this conversation going to carry on? Because I can see you, and I've got more people who want to speak. And Camilla is saying, so hold the thought. I'm going to come back to you after two more interventions. How are you going to carry this conversation on? Who else needs to be in the conversation? And what is the kind of, where are we going to get to? What's going to help people see that actually we've moved from having an interesting, useful conversation to something that's going to make a difference in the NHS? So I'm going to go to you, and then to you, and then we'll come back to the board. So, Kieran, do now hand over the microphone that way. Thanks.
What I'd like to throw into that mix is that we actually need to look at parity of esteem, which is the link between physical health, mental health and well-being. We will improve health, we will save the economy money, and we will have less staff sickness in the NHS. And the other thing is we have to look at the whole person. We have to look at the whole person's needs, not just the thing that they present in, the broken ankle or whatever. We also have to get to work together with the statutory, the voluntary and the public. We've all got to work together on these issues, because if we don't do that, we're never ever going to improve health and well-being in this country. But parity of esteem is a must.
This comes back to the invisibility issue, and think the reasons that communication may not be happening is because of the things that are invisible, because we're treating one thing and not another, an esophagus and not a person. Yes.
Hi there. I'm Farah from the Race Equality Foundation, and I just wanted to say that in terms of what Victor's saying, I think it's a no-brainer to involve the most marginalised at the point of design, but also that we need a shift in the way that we view and look at accessible information. I think in the past it's been seen as something that's very specific for specific groups. Well, it actually has a much wider remit, and I think by default it's useful for most people. Accessible is useful for most people, and those people need to be involved in the design of it from the start. So, for example, for us, it would be English as a second language. There's a lot of cost that can be saved in terms of translated documents if it's done well. It's a useful document, that accessible information for people across the board.
Thanks, Farah. Thank you. So, I'm going to go to Tim and then Victor, and then I'll tell you what's going to happen straight after that. So, where is the conversation going to go on, and what's going to change, or how are we going to know it's going to make a change?
So I think it's been a really rich conversation. Right now we have committed to thinking really differently about the public information related to the care.data programme. So this is a moment where I can demonstrate to you that we are going to do exactly what Victor has said, which is to set the benchmark of information about some of the opportunities and rights people have, in this case, to decide how their data will be shared, so that particularly people with learning disabilities, but others absolutely get what's going on. So I think I've got an opportunity to demonstrate that. We will be coming forward with proposals, having consulted really widely, and these will be co-created proposals in about 3 or 4 weeks' time. So hold me to account for that, and then it would be great to bring that back, and see what people thought. But this is a time, in a way, although it's all been a little bit awkward, frankly, to say the least. Actually, it's a really big opportunity because this is a moment where we can demonstrate that we are going to be genuinely true to the values we've promoted, which are exactly the ones that Kieran and Victor have promoted. So that's one specific thing. I think the second thing is that, and this sounds a bit tedious and a policy issue, but actually we run a whole sort of part of NHS England is running something called information standards. These are the requirements that the system has to do things like make information accessible on a whole level of really different basis. So some are really technical and others are really just about public information. And I think what we need to do is to work with the Assembly, with NHS Citizens, to I'm not allowed to call it an assembly, I don't think.
This is an assembly meeting.
Oh, this is the assembly, but not their assembly. Okay, sorry. To work with... Oh, my God. Oh, I'll go with the programme, Kelsey.
If it's confusing to the board, we can be...
No, I'm not confused. I'm just under such strict instruction about the language. But anyway, to work with the NHS Citizens and the movement and everyone, really, as far as we can, on making that work better. So, to set some standards for health services that we commission to start thinking very differently about making sure that it communicates, going again to what Victor said, communicates whether it is authentic and accessible to all communities. So those are two specific things that I think I can talk now. But we will take this back. We have a board meeting anyway on Wednesday. We will take this back and we will make some progress.
Right. Well, I mean, I agree with everything that...
Hold it up closer.
All right, OK. Can I just start with the care.data thing? Because I might express a kind of view as a board member. The first thing is to say is that it's a no-brainer. It's a good idea. I mean, I think Tim's taken a lot of personal flack, which I think is quite a lot of which has been totally unfair. There's about 1% I'd absolutely agree with, to be honest. But we need to address care.data as a board as opposed to leaving it to an individual on the board, which I think has been really, really unfair on that person. The second thing is we need to have the humility to learn. So, yeah, we cocked up, right? We should have done some stuff that we didn't do. Sorry, we're not perfect. We're just a bunch of people at the end of the day. And so what we need to do is co-create the next iteration, the next cycle with you, which is one of the reasons why we have NHS Citizens. We can learn to get it right the next time and get it better. And let's try some things. Let's start with the most least likely to know what care.data is and then build it out from there. I think the parity, somebody mentioned the parity of esteem issue. I just think that's going to come back and bite us on the derriere if we don't discuss it at the board, and we have never discussed it at the board. So we do need to do some work around that. I guess I'd end by... this is fantastic. It's just invigorate. For me, it's like, why am I on a board? So this is brilliant. So we have to find a way of making the board push out to you, hear, not just hear you, but listen, and then respond in a way that's creative. If each one of you tell 10 other people to get in touch with NHS Citizens and join, we've just made you 10 times bigger. And that's what it's all about. So we have to co-create the NHS Citizen with you. So that's what's going to drive the board. If we get this to work, it will drive the board, not the other way around. You're paying for it. So you need to drive it. So that's what's going to be on the agenda for me anyway as a board member. And every other board member will disagree with me. But that's not what's on the agenda of the board. It's good. That's good stuff. Sorry, yes.
So I just want to tell you what's going to happen next and then leave the final word to Camilla wants to say something and then to Kieran. So we've opened a conversation. We've had some resolution. I think there are some other things we want to hold you to account, and the NHS Citizen team will follow up a number of the threads. There are people we need to draw into the conversation, and we have to think about who they are. We want to also understand what you think about how this has worked. We're going to do it almost straight after this. So if you're interested in coming back with us and reflecting on how this worked, then we're going to let Jeremy Hunt speak first. We don't want to drag all of his audience away. So we're going to meet at 5 o'clock back here. We realise it's late at the end of a 2-day conference, but we're going to come back here at 5 o'clock. If you can't come back then, or you're just too exhausted and can't be bothered, grab a member of the NHS citizen team and speak to them and give them your reflection, feedback. There'll be lots of chance to feedback at multiple stages, and that's really the next thing that's going to happen. We will be keeping these guys to account. We will be holding them. There'll be more things we want to ask them. Where is this conversation going to carry on? And we're going to reflect on how this has worked as well. Camilla, and then Kieran, and then we will stop.
I was just listening to Tim saying how acutely uncomfortable it could be. And we know that it's really brilliant that you can come, and it's actually quite difficult for some people, but more straightforward to others to speak, as we have called it in the NHS, and to speak truth to power. And we know that it's difficult to sit there with your back against the privet hedge. But we wanted to thank you all for participating in the first of this series of exercises. And what we really hoped for was to pull off something that was about holding the board to account, but having it as a conversation and not a fight. And I think that maybe we might have gone some way to achieving that, so for which we thank you very much. Simon's going to give Kieran a job by the sounds of it.
Well, I want Kieran to just take that last reflection. I've just been told a really practical point. If you haven't yet been scanned, one of the things we had to do for the legitimacy of this thing is say who was here. So go and bother Ali there and get scanned so we know that you were in the room, or Clive, or Tilly behind me, or people waving, whoever they are. Boring stuff. Just the kind of where have we got to and what happens next, and what have you taken away?
Well, first of all, thank you guys as well for helping with this. Can I go back to the beginning when Joanne and Sean said jargon-free, supported information, and then we had the comment about in the community and how we do this is important. Is there anybody Welsh here? One Welsh person. In my day job, we produce information in Welsh for people in Wales. We would not dream of doing that without talking to a native Welsh speaker. Why do we imagine that if we're trying to deliver information to the travelling community or people with learning difficulties, that we can do it without talking to them? We wouldn't do it in Wales, so why do we do it anywhere else? So I think that principle is important. I'm absolutely with Victor on his thought. There's something else for me around having a success, and maybe it's care.data or maybe it's something else, but if we as NHS England, and don't remember we're not the whole NHS, we have to role model this so that all of us can then point and say, if you want to do it well, go look at that. They did it really well. So if the next time we meet, we have something we can say, do you all agree that we did this really well? I think that's the success for me. And then what we need to do as the board is say, let's set up the next conversation like this. Don't know where it'll be, don't know in which town or which city or when, but let's promise to do it somewhere before the year is out. And my last thing is it needs to begin to be the whole board, not just Victor, not just me, not just Tim. There's a bunch of others as well, and they need to be here too. Thank you.
Fantastic. Thank you all very much. We may or may not see you at 5, but we're really delighted you took part. Thank you all very much. Thank you.
Hello everyone, it's 5 o'clock and we said we would be reflecting on what happened in the Assembly about 90 minutes ago. I am going to make sure we finish absolutely at the very latest at 5:30. And so I want to get a couple of people to give their reflections. You'll have noticed that Catherine and I were sitting there typing away as we kind of watched the dynamics and watched what was happening in the space. So I'm going to give the mic to Catherine to give her first thoughts in a moment. But then it's just going to be a very general discussion. We are being webcast. So, again, this is part of our open documentation of what we're trying to do. So feel free to sing out. And Ali has a mic that he can take round for people to comment. Very unstructured. The one thing I would say is the question is, how was it for you? And the question we want you to ask us, or the task we want you to give us, is what are the things we need to be most urgently working on in the next iteration of the development of NHS Citizen? So, Catherine.
Okay, so thank you everyone for coming back to this session as well. We really appreciate it. There's a number of things which I noted, and I'm just going to test on you as to if you thought those made sense as well. I mean, the first thing was a piece of learning both that came out of the content of the session, but also I've been hearing all through Expo, which is how do we involve some of these hidden voices in our design process? Because if we don't involve them in the design process, they're not going to be in the system at the other end. And that seems like a really obvious thing, but actually I'm taking that away personally as we really have to figure that out. That sort of links to one of my observations about how the session ran, which it's quite difficult to make sure that there's space for people who've got very different needs from the session, irrespective of accessibility needs, very different needs from the session, to be able to actually participate and to make sure that everyone is giving them the space to participate. So there's some modelling about the actual interactions as well. Another observation I had was that I think it turned into a very human set of interactions, I felt, which was a really good thing. And I think it's good for all of us to see the board members being human. And I think it was really good for them to be put right in front of real humans. But I think we're going to need to do some work on how we make sure that they feel able to actually commit to action from that session. It's a very difficult thing to be able to have some very free-ranging issues come up and then to figure out exactly how to respond in a way which is authentic and manageable, but doesn't actually end up with them getting into more trouble when they try and actually do it. And I think we managed it on this particular issue, and I think Tim's pledge was great. But as ever, I think that there's a mixture between things we could do something about and things which actually will need more working on. And I guess that was my other observation. I'll make it my last observation, which was that when we get this... Oh no. No longer can I make an exhibition of myself. We are occupying the space. Is that, no, we're here. Don't kettle us. So when we're doing this as a whole system thing, then obviously you'll have had a much more in-depth conversation about the issue as part of the gather process, and probably you would have been able to spend a little bit more time laying out the evidence than we were able to do. And I guess it's how do we make sure that we keep the passion in the conversation of people really wanting to advocate for their ideas at the same time as making sure we've got really strong information in the space as well. Because we're going to have to bring both the passion and the information if we're going to turn it into decision making. So that's me that's slightly free associating on it. So
I have to snatch the mic in the end. Who else would like to come in at this point? Okay, so Charlotte and then John.
Yes, I wanted to finish the conversation I wasn't allowed to finish previously, which was, I'm banging about the NHS, but there were ladies in the front row here during the conversation, one of whom, on the second row, stated that she very much appreciated the NHS. It was a wonderful organisation. And I believe it is a wonderful organisation, and I believe it is well worth fighting for. And I think we have to fight to make sure it remains the way we'd like it to be as we move on. I'm also coming back on the fact that I've stated that the NHS employees at the front end of the NHS need to be retrained so that they look at the needs of the public that they serve first. But to add to that, I would say that where you are a professional already and something new comes up, like the Mental Capacity Act, for instance, which you are not trained to deal with, there must be some method of helping people so that they're not left standing on one leg, feeling terribly embarrassed, when they've been doing their own job for many, many years and doing it extremely well. Certainly it did, but it needed to go on a lot longer. I think we'll need many more conversations. We need people to be listening and acting, and I think this is a very good sign. I'm utterly delighted with what's gone on here, I must say. Thank you.
Well, the first question Catherine asked was, how was it for you? And I've attended lots of focal groups and all that, which tend very often to finish up as adversarial meetings. It's great to say this one didn't. No one was banging their own agenda. Yes, they did say who they represented, but the whole thing, everything was a consensus or covering other people. So, yeah, for me, it was fine. And the second point really is a very important one, and I was amazed when Victor stood up and put his neck in the noose, basically, to say, look, we have got things wrong at times. How can we actually go back to a new start and start on the basis that we need to get people involved, whatever their level of capacity, whether they have mental problems, whether they have physical problems, whether they have family problems or whatever. And I think that's a wonderful thing, and I really hope that that's taken up. And as I say, I think Victor was very brave, actually, putting his neck in the noose, but I applaud him for it.
Thank you. Thanks very much. Thanks very much. Who else would like to come in? Olivia?
So, yeah, that's been quite a fun 2 days. Haven't we learned a lot? And haven't we had some good conversations? So that whole session, the thing that really struck me is we constantly do conversations in our own community silos. So, and we do it, we facilitate things all the time. So we talk to young people here, and we talk to the trans community here, and we talk to the self-advocates there. And what was really special, and just watching who joined the Assembly conversation, the diversity and depth of people who chose to come and join was phenomenal. That mix, and everybody very respectfully listened. So that thing of it didn't turn into a town hall argument. It was a conversation that people wanted to join and be heard and start to understand where our issues connect with one another. So it's not always about competing. They're going to kick us out.
Ladies and gentlemen, the power to all stands will be turned off at 5:30 p.m. Thank you.
They really want us to go home? Yeah, the security guards are now nodding at us. This is our wrap-up session. Okay. Okay. Cool. So, I'll stand it then, because they are going to kick us out, and then we'll get really badly told off. Yes. So we will, the commitments, okay, there's something really important. We will be following you all up. We've scanned you. We know who you are. You can't escape us now. So you will get an email from us that will give you some stuff. It will point you to some blogs. Have a look at the website. If you're on Twitter, please tweet and join that conversation. If you're not online, then, you know, we will email, we will keep this conversation going, and we will get dates out for the different tests and experiments we're starting to build and develop around the country. Thank you very, very much for joining in, and a big round of applause to all of you.
So everybody home, thank you all again. Thank you to the contractors for giving us that little window. And I think it's a systemic reflection of the importance of time. It's very important. We don't lose that.